Well, hello and welcome to the fourth of our CSF podcast focusing specifically on psoriatic arthritis. We'll be bringing you new episodes on a bi-monthly basis as well as our AXSPA podcast. We'll also be supplying you with monthly slide decks to help keep you up to date with the latest research and publications in the field of psoriatic arthritis. I'm Professor Iain McInnes from the University of Glasgow, and today I'm joined by Dr. Frank Behrens from Goethe University. Frank, over to you.
Thank you, Iain. Great. So we have papers they will covering today's topical discussion a little bit related to new novel therapies and how they fit to the treatment algorithm and in comparison to other products who are already on the market. Our first paper seeks to examine the efficacy and safety of ixekizumab in patients with PsA and psoriatic skin disease. And our second paper today will highlight the, let's say, comparative efficacy of multiple treatments in psoriatic arthritis. And of course, they are not focusing only on a head-to-head trial, they are focusing on a network meta-analysis. And I think you are part of the other team, but I have the honor to demonstrate the outcome of this manuscript.
And that can only go badly for me, Frank. So a man of your great intellect looking at our work is giving me concern right now. But hey, over to you. So look, why don't I talk about the first paper and then we'll think about what it means. So the title of this particular paper, Efficacy and Safety of Ixekizumab versus Adalimumab in biologic-naive patients with active psoriatic arthritis and moderate to severe psoriasis. Remember the combination of the two 52-week results from the randomized Spirit head-to-head trial from Reich and colleagues. Well, a little bit background here. I think everyone is aware that successful treatment of both the joint and skin domains is vital if we're going to achieve the right outcomes for our patients with psoriasis and psoriatic arthritis. And the whole concept of only treating one part of a patient is very last century. And for patients with an inadequate response to conventional synthetic DMARDs, the EULAR and European Dermatology Forum recommend the use of biologics targeting inflammatory cytokines. As higher rates of skin clearance have been observed for the 17A inhibitors as compared with TNF inhibitors, the comparative efficacy of these biologics in people with concurrent PsA and moderate to severe psoriasis is clearly something that we're all interested in. And we have seen some of these data before. We saw them with the earlier time point, and what we get to look at now is the 52-week data, which in many respects is a more relevant time point for those of us in practice. We don't see someone in clinic with a chronic disease and say, well, I want to see what you're going to be like in 3 months, and then I wash my hands of you. So these are relevant data to our clinical life. So the key headline results, well, first of all, more ixekizumab as compared with adalimumab treated patients simultaneously achieved PASI 100 and ACR 50 at week 24. We knew that already, and week 52. So week 24, it was give or take 41% as opposed to 17.5% for ixekizumab, adalimumab respectively. And at week 52, 39% versus, again, 17.5% with the ixekizumab versus adalimumab. Now, note well, combination of a PASI 100, so that's clearance of skin, and an ACR 50, which is a sensible high hurdle musculoskeletal response. Now, similarly, more ixekizumab versus adalimumab treated patients achieved PASI 100 and PASI 90 through week 52 and nail psoriasis clearance at week 24. The joint symptom improvements were comparable between groups and no new safety findings were reported. Let me just repeat that. The joint symptom, that's the musculoskeletal compartment, they were the same, which is kind of interesting. So let's take the conclusions. Ixekizumab, higher efficacy than adalimumab in simultaneous achievement of ACR 50 and PASI 100 at week 24, and now we know at week 52 also. And the ICSI-treated patients showed higher response rates for nail clearance and reporting minimal or no impact on quality of life at week 24. So interesting data. I'm not hugely surprised, Frank, about these. I think they're what I would have expected. What about you? How do you feel about this?
No, I remember very well when these two head-to-heads came on the market, which is the ICSI and the head-to-head. We had a lively discussion about a new creative endpoint combining ACR 50 plus a PASI 100, knowing that at least one of these combined endpoint parameters are already demonstrated to be superior. So on the one hand side, I would say it's not surprising, to be honest. So we had this head-to-head in skin psoriasis anyway. We have, I think, a clear ranking in the skin psoriasis outcome right now. So showing that the 23s and 17s are at the top. And then we can discuss whether Baimer is a little bit superior to Ixe or Seku, but nevertheless, we have a ranking up to down to etanercept as the weakest skin biological approved for PsA and psoriasis. But yeah, on the other hand, what's wrong if you can promise a patient that complete skin clear skin
absolutely
50% reduction in musculoskeletal is superior in one product compared to the other? So I have a kind of two views on it. I think it was an elegant selected endpoint, to be honest, with no surprise. But nevertheless, the message for a patient, at least in those with substantial skin involvement, is a clear message. So the probability to achieve remission on skin and at least 50% reduction in musculoskeletal is higher in the Ixe. But to be honest, I think if you analyze it, these data of the EXCEED study in the same way, it will come up in a comparable result.
Yeah, I think those are really fair remarks. I've got to be honest, when I looked at this combined primary outcome at the very first, when I looked at it in clinicaltrials.gov, if I'm honest, I thought it was a little bit, I thought it was an interesting choice of primary because, as you very wisely point out, we already knew that one of the drugs could beat the other drugs in one of the tissue compartments that was part of the primary. On the other hand, to be completely fair to the study, we're trying to treat all of the tissue domains in our patients. So, and I guess what I would love to see now is maybe, and I know this is not what the MDA, minimal disease activity, was ever really designed for, but starting to set that up as an outcome, a primary outcome, and then see how we get there with these highly effective therapies across different tissue domains, that for me would be very, very interesting indeed. And to be fair, it's in there in this analysis, but maybe what we'd like to see in future is just to guide us in those, targeted therapeutics. And of course, we also have to think about the arrival of targeted synthetic DMARDs, the JAK inhibitors. Now, let's leave aside controversies about their relative safety. In the kind of young patients with psoriatic arthritis, I think that's probably an irrelevant discussion, or largely irrelevant discussion at the moment. So yeah, interesting study. Nice to see the sustained responses. Any surprise for you in the sustained nature of the responses? I mean, things have stayed reasonably robust, maybe dropping just a little, and that slight downwards. We've seen that quite a lot with the 17 inhibitors, haven't we?
Yeah. I think it was important to see now these 52 weeks data properly, because again, combining two different studies, the EXCEED study had the primary endpoint at week 52, for example, and they have it earlier, and I think the value of these studies that they were already performed. And I think the value of the studies, for me, to be honest, is independent from the primary endpoint. I think it's absolutely okay that a company tries to figure out an endpoint which emphasizes the strengths of the product which were already known. So nobody is going to the board of directors and say, come on, I do a clinical head-to-head with a comparable product and I have no idea whether I can beat them or not. But the chance to get this study on the street is higher if you have an elegant endpoint. I think that's fair, but I think there's so many data and they are doing a lot of analysis step by step following the primary endpoint to better understand the value of the individual product, and I think that's fair. And you pointed out maybe the discussion about loss of efficacy over time, secondary loss of response. I think most of these discussions are driven by the derms. Specifically with the ECLIPSE study, where Seku in psoriasis were compared to Guzelku, where you see that in the long run the line is a little bit dropping in Seku, while in Guzelkumab it's running on the same level. So yeah, it's important to have these 1 year data and don't see a robust loss of response. That's an important message for the long-standing disease.
Yeah, spot on. And of course, the other thing we should be celebrating here is that this is a head-to-head trial. Yeah, and we've been really short of head-to-head trials in rheumatology in general.
Yeah, this is why my next paper isn't head-to-head, because
absolutely. And actually, I'm going to hold you back for 10 seconds before we, because actually that's really precisely what the next paper is about. But worth just reminding our audience that it's not the only head-to-head trial we have in the literature. We also have the EXCEED study, where we compared ixekizumab and adalimumab, and pretty much superimposable results. That was an interesting study in that the primary outcome was at 1 year, which is a very interesting design. Actually, quite a risky design for the investigators. I was one of them, so I'm happy to declare that. But I think what is quite reassuring is that two different study populations, at the same general entry criteria, but two different populations, treated 17A versus TNF inhibition, and the results are essentially the same. We see superiority for the 17A mode of action when we're combining skin and musculoskeletal outcomes, and in the musculoskeletal compartment, broadly similar results for 17A and TNF inhibition. But it's really great that we have these head-to-head data. However, the truth is, Frank, we don't have head-to-head data for quite a lot of the modes of action, and that does bring us very nicely to our second paper. So I'm getting terribly tired. So why don't you take over now and tell our audience all about the next paper from Philip Mies and his colleagues. Over to you, sir.
So yeah, thanks. Hopefully you are not too tired to listen a little bit to these data because you are a co-author. Network meta-analysis. So what does it mean? So normally it's always the same. This is done when missing head-to-head data. And I think as we as Germans are automotive country, I always compare it to car races. So the method is always if a Ferrari drives against a Golf in a race circuit, and we're looking what's the distance between the Ferrari and the Golf. And then next day, a Lamborghini is driving against, or an Aston Martin, because I have people from the island, drives against the Golf. And then we're looking for the time difference between the Golf and the Aston Martin. But the challenge is always, in one day we have wet course, another one we have a dry course. It's raining, it's sunny, it's morning, it's evening.
Brilliant analogy. I intend to steal that. That's a brilliant analogy. I like that very much, Frank. Yeah,
it's not allowed to steal it. It's no, for sure.
I'll attribute it to you.
Yeah, it's definitely the same Golf, but the temperature of the tires is different, and all these things. And I think that's a weakness if you don't have direct head-to-head. This has to be in mind. But of course, there is in these Bayesian and meta-analysis, there's a lot of tricks, let's say, to deal a little bit with these differences. But nevertheless, these changes and differences between Monday and Friday, race course situation on different days, and all these things has to keep in mind to understand the wind is different. This is why placebo or the Golf is sometimes faster than in the other cases. So that's my very stupid explanation what a network meta-analysis might be. But nevertheless, we can understand, and everybody would believe that both Ferrari and Lamborghini might be faster than the Golf. So, but now in daily practice, we have to choose. Neither the EULAR recommendation nor the CRAPA recommendation give you a clear hierarchic order what kind of product, what kind of targeted synthetic or biologic should be chosen if you fail a previous therapy. And of course, this is what we have to do. Therefore, it helps us to understand in this paper titled Comparative Effectiveness of guselkumab in psoriatic arthritis, update on a systematic literature review and network meta-analysis by Philip Mies and colleagues, addressing this issue. And of course, a lot of Janssen people are part of the author list. Of course, there is an idea why to do it, but the method is clearly described. Therefore, we can trust what we can see with all these caveats I mentioned earlier during my presentation. So we have a lot of randomized clinical trials, and you mentioned it already that we have limited head-to-head trials. We have only the UPA. In addition, the upadacitinib trial with adalimumab, where you were allowed to make a statistic analysis as a direct comparison and not having only a comparator arm. But that's it. There are some network meta-analysis out already in the past from guselkumab, but they are missing data from ixekizumab and upadacitinib included. And this is the update, so to say. And the objective of this network meta-analysis is exactly what I mentioned: expand the analysis with new targeted therapies and new biologicals, and not only focusing on ACR, but also including skin efficacy and safety, and in this analysis also radiographic inhibition of radiographic progression to compare it with all these available products. So what came out? You all know there are a huge number of trials out against placebo. Though we have the PALACE program from Apremilast, we have the KEEPSAKE program from risankizumab, we have the SUMMIT program from USTE, and so on, this cover program from guselkumab, and not only UPA and RISA is now newly included in this analysis, but also the COSMOS trial data from guselkumab, another reason to update the previous published analysis. So what the outcome for ACR20, guselkumab 100 milligram every 8 and every 4 weeks were comparable to most other agents, including risankizumab and UPA, and sub-Q TNF. Why sub-Q? Because in all these analyses, IV golimumab is included, which has outstanding good results in many domains, but I think it's not widely used in daily practice. But this is why I mentioned sub-Q TNF inhibitors. And it's comparable to most of the IL-17 inhibitors. So for PASI 90, guselkumab were better than multiple agents, including sub-Q TNF and JAK inhibitors. And for inhibition of radiographic progression, Van der Heide sharp score, guselkumab was every 8 weeks was similar to RISA, while guselkumab every 4 weeks was better. So why is this pointed out specifically? Maybe most of you were aware that guselkumab every 8 weeks missed the endpoint to be superior in inhibition of radiographic progression against placebo, while every 4 weeks met. And this is interesting. This is why we have this kind of, let's say, interval flexibility, because in those with a high risk of progression, we were allowed to do it every 4 weeks. And I think this definition can be done by the physician, because we have no stringent criteria that it must be 20 erosions or CRP or whatever. This is why it's stated here. So the 8 weeks is comparable to RISA, and the every 4 weeks guselkumab was a little bit superior, and the 4 weeks met the criteria as an endpoint in the clinical trial, while every 8 weeks not. So the skin efficacy, in conclusion, is higher. That's what we expected as well. We have robust data on the inhibition of radiographic progression of guselkumab comparable to others, despite the fact that the every 8 weeks didn't met the superiority to placebo in the clinical trial. Both guselkumab doses demonstrated a comparable ACR responses to most other agents, including the new integrated products like UPA and risankizumab. Yeah, and I think the safety profile is very good for guselkumab. That's what we already learned. What we already learned from ustekinumab, that this mode of action seems to be very safe. Yeah, and maybe these network meta-analysis might help us to understand the value of guselkumab, despite the fact that we are missing a head-to-head trial. Yeah, and over to you, Iain.
Yeah, no, Frank, thank you. That's a brilliant synthesis. I really do love your analogy. This idea that and these meta-analysis approaches, there are strengths and weaknesses. The principal strength is that this is a validated methodology. It comes mainly from the health economic literature, and it relies on the performance and behavior of the placebo group, which in your analogy is the Volkswagen Golf. By the way, the Volkswagen Golf is a very good car. Just in case there are any Volkswagen drivers listening, it's a great car. There's nothing wrong with it.
Absolutely, sorry.
Yeah, no. It's a good family car, probably more comfortable than a Ferrari. But the point here, of course, is that you have the idea of outperforming the placebo, and the distance by which you outperform a placebo then allows you to make these cross-drug comparisons. We have a fair degree of consistency in the way in which we recruit clinical trial populations over the last 10 years. We've seen a little bit of drift. We're seeing slightly less severe disease activity, although actually it's held up pretty well in the PsA space, maybe more so even than in rheumatoid. And as such, I think this should be taken as indicative rather than as fact. So when you're in the clinic and you've got a patient, you have a range of MOAs available to you, you look at the EULAR guidelines, EULAR recommendations rather, or the GRAPPA guidelines, you say, look, this is what I've got in front of me. Okay, there was a meta-analysis. This is probably at least as good a choice as the other. And if you put these two studies together that we've talked about today, Frank, I think there's now a clear line of sight in a patient who's got severe skin disease and musculoskeletal disease. I think we are definitely there thinking about 17A inhibitors and P19 inhibitors. Whereas if there is we're a bit neutral around the skin and it's musculoskeletal, well, then I think you're definitely thinking about the possibilities of a TNF inhibitor, or for that matter, by the way, a targeted synthetic DMARD, a JAK inhibitor. So
yeah.
I wouldn't put too much more emphasis on this study beyond that. It's giving us confidence as clinicians, but it doesn't have the power of a head-to-head trial. Exactly. I don't know what your thoughts are, because clearly I'm an author here, so I have a conflict of interest on the methodology. So I'm happy to be criticised as ever.
Yeah, no, I think you're absolutely right. And my question in daily practice is, how do we define a relevant skin involvement driving our decision towards 217 and P19? I'm so excited and a little bit confused and surprised by the derms. So I think they mainly skipped TNF completely for their armamentarium, at least in Germany. So if this is an indication for systemic therapy with biologics, why should I waste time for TNF inhibitor with a relatively weak response? But to be honest, in rheumatology setting, with all the musculoskeletal domains, we have no strong arguments not to do a biosimilar TNF or TNF anyway.
Absolutely.
Because in all the trials, in the head-to-head as well as the network meta-analysis, it is comparable effect size. The only superiority in musculoskeletal domains, as far as I know, is indeed the UPAR 30 milligram, which is not licensed to use, against TNF. That's the only mode of action where I have ever seen a really significant superiority in an ACR 20 response compared to adalimumab in this phase 3 trial, where it was allowed to calculate the differences of the different arms. Yeah. But in the 30, in the 15, we are definitely non-inferior of UPAR, but that's it. For all the others, the skin domain is a game changer and the driver for decision. And what I learned in the past from the derms, that an absolute PASI is no longer what they're looking for to understand the severity. So I was really surprised to see data that a DLQI of 1 or 2, which is no relevant impact on life quality based on skin, this is what DLQI is measuring, it can only be achieved when you have a clear or almost clear skin. Means what patients are expecting from us treating psoriatic disease, not only arthritis, if we name it psoriatic disease, with the skin, means they want to achieve almost clear skin independent from the absolute PASI. And this, I think this has to be taken into account by treatment.
No, I couldn't agree more. And it's lovely to see that our dermatology colleagues are now as ambitious as we are in rheumatology to really get our patients to that minimal or very low disease activity state. So thank you. Frank, as ever, I've learned such a great deal from you. I love chatting to you. I always go away from these podcasts knowing more than I did at the beginning. So I'm very grateful to you and of course to all of those of you who have joined us for this PsA podcast brought to you by the CSF. We really do hope you've enjoyed it and found it useful. And of course, if you did, or actually I suppose even if you didn't, don't forget to subscribe to our channels on YouTube, SoundCloud, or wherever you get your podcast from, so that you won't miss any future episodes. And of course, if you want to read more about what we've discussed today, head over to cytokinesignaling.com. That's cytokinesignaling.com. You're going to find detailed summary slides of each of the papers, abstracts, and a ton of other really, really useful material. So thanks once again, Frank, to you for joining me, and to you, our audience. I hope you found it useful, and we're looking forward to seeing you next time round. Thanks ever so much.
What a pleasure. Thank you.